Hello, welcome to the Oncology Bootcamp Introduction to Chemotherapy section. We are going to discuss the most commonly used agents at Jackson General and the Kirkland Cancer Center. As you guys know, there are over 200 or so agents currently on the market and many more receiving approval each and every month. For instance, in 2018, we had roughly 30 new approvals in the oncology world, so that's a lot. So as pharmacists or pharmacy students who are becoming pharmacists, we are expected to be the medication experts, and trying to keep up on several hundred agents is nearly impossible. So we are not going to cover everything here. I'm gonna touch on the most common agents that you might come across while on rotation, as well as what the NAPLEX might ask you. Okay, so looking at the objectives here, pretty straightforward, I think. We're going to classify chemotherapy agents as either cell cycle specific or non-specific. And then given an anti-cancer drug, what's its mechanism of action? And what are some common and noteworthy toxicities? And then finally, what are some indications for those agents at the Kirkland Cancer Center? So looking at chemotherapy basics, there's a lot of information to remember and to know. If you pulled up methotrexate, for instance, on LexiComp or our Drug Information Handbook for Oncology, there's a lot there. So what is most important for you guys to know? So I'm going to go through and try to highlight the important concepts and principles as we progress through this lecture. I do want you to know mechanism of action, okay, and what class it belongs to. Again, is it cell cycle specific or non-specific? Common toxicities for this agent, okay, as well as perhaps common toxicities for the class. So for instance, vinca alkaloids are known to cause peripheral neuropathies. So all agents in that class cause it. What are the dose-limiting toxicities for these agents? Okay, what dose can we not surpass without having severe myelosuppression? And then what are some medications that we might need to give with the chemo agent to treat complications or to prevent complications? So thinking of methotrexate, again, a common drug given with it tends to be leucovorin, right? So I think that is important to remember. And then what agents can we give to potentially enhance the agent? So again, looking at leucovorin, we give that with 5-fluorouracil to help enhance the activity. All right, so looking at dose-limiting toxicities, these are side effects of a drug that are serious enough to prevent us from escalating the dose. Okay, so myelosuppression tends to be the primary culprit, the primary reason why we cannot give bigger doses, because if we do, the bone marrow is rapidly dividing. Okay, it's almost always in the cell cycle at some point, and so we're producing billions, literally billions every hour in our bone marrow, and so if we give chemotherapy, it's going to kill those rapidly dividing cells, and if we give higher doses, our bone marrow might not recover. Okay, so that tends to be the most common dose-limiting toxicities. Other ones that we'll come across: nausea, vomiting, neuropathies, diarrhea, and so on. So just quickly reviewing the cell cycle. So most cells in the body, we've got 100 trillion cells roughly, and the vast majority of those are in G0. They're in acquiescence. They're not doing anything as far as division goes. They're doing their normal job. So a hepatocyte is doing what it's supposed to be doing. It's not dividing. However, when it goes into the cell cycle, it enters at G1. Okay, and G1 is we're getting ready for the S phase. So we've got synthesis of cellular components that are going to be needed for the S phase. And then we enter into DNA synthesis in our S phase, which is where DNA polymerase goes through and replicates the genome. And then in G2, we're essentially getting ready for the M phase. Okay, so synthesis of cellular components that are needed for mitosis. And then the last phase is those microtubules pull apart the sister chromatids, and you have two separate cells after that. So we have chemotherapy that works inside the cell cycle, These are cell cycle specific agents. Then we have some that act indiscriminately. They don't care if the cell is dividing or not. Okay, so the two major classes that are cell cycle non-specific are the alkylating agents and the anthracyclines. Okay, almost everything else is working somewhere within the cell cycle. Okay, and so it's dependent on the cell to divide in order to exert its cytotoxic effect. So this slide here just kind of shows you that graphically or visually. So you've got your cell cycle non-specific drugs. There's lots of them because, as we'll talk about later, alkylating agents are the oldest and the largest anti-neoplastic class that we have. Anthracyclines are kind of the other major class that work outside of the cell cycle. And then we have our antimetabolites. Okay, these are folate antagonists, antipyrimidines, antipurines. We've got our topoisomerase inhibitors, topo 1 and topo 2, and then just some miscellaneous drugs like bleomycin, and then our antimitotics, so vincas and taxanes. So let's first talk about our cell cycle specific agents. Okay, so these work in a certain part of the cell cycle. So for instance, methotrexate is working in the S phase. So the cell has to be in the S phase or entering the S phase or trying to leave the S phase in order for methotrexate to lead to cell death. Okay, so these tend to be effective for malignancies with rapid turnover. So they're entering the cell cycle frequently. Okay, typically require multi-dose courses or continuous infusion. So a good example of this is 5-fluorouracil, which is a cell cycle specific drug that works in the S phase, and we give it continuously over 48 hours. So patients will come into the KCC and we'll hook them up to a pump, and it goes for 48 hours, and then they'll go home and they'll do their thing for 2 days, and then they'll come back and we'll unhook them and the drug will have infused for 48 hours. And the thought behind that is anytime a cancer cell enters the cell cycle, there will be 5-FU there to kill it. So these are schedule dependent. Okay, so timing is really important. You could have a lot of 5-FU on board and in the system, but if the cells aren't dividing rapidly, it's not going to cause a lot of cell death for the cancer. So schedule dependent. All right, so the classes we have, major one, antimetabolites. We've got some antimicrotubules, we've got topo inhibitors, and then bleomycin. We won't talk about corticosteroids because hopefully you guys have a good understanding of those already. So antimetabolites work in the S phase. So these are structurally similar to RNA and DNA, and so they compete for binding sites on certain enzymes, or they're so similar that they're incorporated directly into the RNA or DNA sequences. Okay, these work in the S phase, and we have those three major classes that we talked about. So the first one here is our folate antagonist, methotrexate, which hopefully everyone is somewhat familiar with. This inhibits dihydrofolate reductase and inhibits de novo purine synthesis, okay, which is needed for DNA and RNA synthesis as well as protein synthesis. So you can see here folic acid, which is B9, is structurally very similar to methotrexate. So Sidney Farber in 1945, 46, 47 came up with some antifolates and started testing them in leukemia patients and found that they had activity with treating rapidly dividing leukemias. And so that started the antifolate phase. Methotrexate was the first single agent to cure a malignancy, and this was in choriocarcinomas back in 1956. So that's a placental cancer after pregnancy. And then we also have pemetrexed, which is similar. So let's talk about how these work. So typically uracil, which is a purine that's being converted, it's RNA, and it's being converted to thymine or thymidine through thymidylate synthase. Okay. Now folate, which we typically consume with green leafy vegetables and lots of other foods in the normal diet, will be converted from folate to dihydrofolate, and then finally into its active form, tetrahydrofolate. So this is done by dihydrofolate reductase, which you guys are familiar with. Okay, this active folate is then a cofactor in the process of creating thymidine, right? So we need lots and lots and lots of base pairs to replicate DNA. I believe there's about 100 billion base pairs in one cell. So we need a lot of these components. Okay, so the body's always producing them. So if we prevent this from occurring by giving methotrexate, then we prevent DNA synthesis. And if we prevent DNA synthesis, then the cell that is in the S phase is arrested and undergoes apoptosis. Okay, and this is also why folate deficiency, or as you can see down here, B12 deficiency, can lead to anemias. Okay, the red blood cells can't produce like they normally do, and they're susceptible to a loss or a lack of these cofactors, and you develop a macrocytic anemia. So I'm going to have charts like this throughout the presentation. The idea here is to kind of show you where these agents are used most commonly at the KCC. So methotrexate, for instance, we tend to see in some leukemia patients, although we don't have a lot of leukemia patients at the KCC. We tend to send the acute ones out to Vanderbilt, but we definitely see it in our lymphomas, see it in rheumatoid arthritis, obviously, and then pemetrexed, we see a decent amount in lung cancer. Okay. Now the complications, these specific ones, we'll talk more about in the next video, but mucositis, nephrotoxicity, hepatotoxicity, and CNS toxicity are all very common, or notable toxicities with methotrexate. And then dose-limiting toxicity is myelosuppression. Okay. Pemetrexed's similar, and we'll talk about the rash in a few minutes. So what is leucovorin? This is our activated folic acid. So it's like THF that we saw in the previous slide. We don't always give leucovorin, so we'll start giving this if patients are getting high doses of methotrexate. So if they're getting 500 milligrams per meter squared or more of methotrexate, then we start to give leucovorin. So if you're getting methotrexate for rheumatoid arthritis, you're not going to need leucovorin. Okay. So when we do give high doses of methotrexate, we need to give leucovorin, and we also need to monitor their levels, and we have a nomogram for that. But that's something that we'll monitor very, very closely, and the pharmacists are highly involved in that. Now, leucovorin is available in two different products. There's levoleucovorin and then the DL-leucovorin. Okay, so if you get just the L version, that's the active. Okay, so the D isomer is not active, only the L. And so with normal leucovorin, we give full doses, and then if they're getting levoleucovorin, we dose reduce by 50%. And so then looking back at our mechanism here and why we administer leucovorin, we need to rescue these patients from the bone marrow suppression that we see with high doses of methotrexate. So we give high doses of methotrexate, we give it 24 to 48 hours to really exert its effect and kill as many cancer cells as possible, and then we have to rescue the bone marrow, because if we don't, the patient ends up becoming aplastic, and they never recover, and they end up dying. So we need to supplement the bone marrow with activated folic acid, so we're essentially bypassing the methotrexate blockade so that the cell can produce, or the system can produce, thymidine, and therefore red blood cells and white blood cells. Okay, so we're rescuing the system. Now, pemetrexed, you also have severe myelosuppression here, so we handle this a little bit differently. So we give folic acid and B12, okay, starting 7 days prior to treatment. and then with the folic acid will continue throughout treatment. Okay. And then this rash that I mentioned, pre-treatment with corticosteroids is not usually recommended to prevent or diminish chemotherapy-induced drug rashes for most drugs. So one exception that I can think of right now is pemetrexed, okay, which is used for things such as mesothelioma and non-small cell lung cancer. So looking at early phase 2 studies, pemetrexed was associated with a papular skin rash in roughly 2/3 of patients. So about 66% of treated patients would develop a rash. This was sometimes associated with edema and desquamation. However, subsequent phase 1, phase 2, and phase 3 trials using corticosteroids showed a significant reduction in skin rash, so less than 20%. And the severity of the skin rash was also significantly less. So we give dexamethasone for all patients who are getting pemetrexed, and we usually give it for about 3 days or so, okay, starting the day before treatment. All right, so moving on from our antifolates into the antipyrimidines, okay, so 5-FU and capecitabine, which is the prodrug for 5-FU that's given orally, are the two major players here. So you guys remember our pyrimidine bases. So we've got thymine or thymidine, we've got cytosine, and then we've got uracil. Okay, so these two drugs are staples in colorectal cancer. Okay, but they do have some noteworthy toxicities. Okay, primarily depending on the route and timing of administration. So our dosamine toxicity varies depending on how it is given. So if we give just a bolus of 5-FU, they're much more likely to have myelosuppression. And then I mentioned earlier the 48-hour infusion. If we do that, patients tend to get diarrhea and stomatitis, which is essentially mouth sores, which are problematic and we'll talk about later, and hand-foot syndrome, which can be very painful. Okay, so those are the primary toxicities we see from 5-FU. Now, capecitabine, when taken orally, it takes a little while to convert it, and so it acts more as a long-acting agent. And so the dosamine toxicities mirror or mimic those that we see in the continuous infusion. Okay, so diarrhea, stomatitis, hand-foot syndrome. So, how does 5-FU work? Okay, so we're essentially adding a fluoride to uracil at the 5 position. This will still bind to thymidylate synthase, but it inhibits it. Okay, so it prevents thymidylate synthase from converting uracil into thymidine. Okay, so thymidine production drops, just like we see with methotrexate. So the end result is the same, but we're coming at it from different directions. Okay, methotrexate, we're approaching it from the bottom mechanism, and then 5-FU, we're approaching it through the thymidylate synthase activity. Now, for both of those drugs, we need to give leucovorin. Why? So with methotrexate, hopefully you see the need to rescue those patients, but with 5-FU, we want as much of this cofactor around as possible because it aids in the binding of active 5-FU to thymidylate synthase. Okay, so we flood the system, so to speak, with this cofactor in hopes that anytime 5-FU and thymidylate synthase are in close proximity, we'll have activated folic acid to encourage its binding and therefore prevent DNA reproduction through the depletion of thymidine. Alright, so what are some other antipyrimidines that we might see? Okay, so cytarabine or Ara-C is a drug that we'll see in leukemias and sometimes in myelodysplastic syndromes, which can be thought of as a kind of a pre-leukemic state. We see this quite a bit at Kirkland Cancer Center, and these patients tend to be older and their bone marrow is sort of flickering in and out. Now, gemcitabine is an antipyrimidine that's used frequently in some of our GI type malignancy. So we see it first line in pancreatic cancer, we see it in head and neck cancer, and it can be second or third line in breast cancer. Common toxicities that we see with these drugs. So in my mind, gemcitabine is usually pretty well tolerated. Cytarabine is fine if you're not getting high doses. If you get high doses for leukemia, you might get cerebellar toxicity. You could get cytarabine syndrome, which is a flu-like syndrome, where you have fevers and muscle aches, body aches. Okay, patients feel terrible. You can get conjunctivitis, which we'll talk about in the next video. But the dose-limiting toxicity for both of these agents is myelosuppression. Alright, so moving on to antipurines. Okay, so adenine and guanine are the two purine bases. So these have two rings, and that distinguishes them from the mono-ringed pyrimidines. Okay, so we don't see a lot of these agents at the Kirkland Cancer Center, but I did want to give you an example of what an antipurine is. So 6-mercaptopurine is a drug I used all the time in little kids that had ALL. So they're on this drug for years. It's an oral agent. They take it every day, and it does have some drug interactions that we need to be mindful of, but for the most part, patients tolerate it pretty well. And again, you're not going to see these at the Kirkland Cancer Center. Hydroxyurea is something that you might see while on rotation, primarily for sickle cell anemia. And if you guys remember, sickle cell anemia, they have hemoglobin S, which is defective, and hydroxyurea actually increases fetal hemoglobin, which is much more efficient at carrying oxygen, and it's not going to sickle. Okay, so most of our sickle cell patients are on hydroxyurea, and that's the main reason we see it. It can be used for cancer treatment, but we don't typically see it very often, especially in first line. All right, moving to our antimicrotubules. We've got two classes here. We've got our destabilizers, also known as vincas, okay, spindle poisons, and then we have our stabilizers, our taxanes. Okay, so destabilizers and stabilizers, they both work in the M phase. They're both disrupting cellular machinery that's required for mitosis. Okay, and as we'll talk about in the next video, microtubules are important for nerve conduction. Okay, so the main toxicity we see with these agents tends to be neuropathies. All right, so vincristine is part of our R-CHOP regimen that we see with non-Hodgkin's lymphomas. Okay, vinblastine is part of ABVD, which we see in Hodgkin's disease. And then vinorelbine we might see second or third line in metastatic breast cancer. Okay, all of these are derived from the periwinkle plant, which are known as vincas, and they are fatal if given intrathecally. So that's a potential Naplex type question. Okay, the constipation here comes from an autonomic neuropathy that results from vincristine use. Okay, and we'll talk more about that in the next video. So just kind of visually seeing what vincristine here does, it binds to the spindles as they're forming, and it prevents the full formation. Okay, so it destabilizes the microtubules that are forming, and therefore prevents the sister chromatids from being pulled apart. And then the cell senses that there's too much DNA because we have twice what we need, and the cell undergoes apoptosis. Taxanes, on the other hand, are a little bit different. Okay, we use these drugs all the time at the Kirkland Cancer Center. Probably one of the top 5 drugs easily that we're dispensing. So breast cancer, so first line in breast cancer, first line in ovarian cancer, and typically first line in non-small cell lung cancer. Okay, so and those are 3 of our biggest players. So we're seeing these drugs used all the time. They definitely cause myelosuppression. Okay, but because they're antimitotics, they cause neuropathies. You can have infusion reactions because these both have a vehicle that causes reactions. So paclitaxel is in Chremophore or castor oil, and docetaxel is in polysorbate 80. So infusion reactions are definitely something we need to be mindful of. Okay, and then patients will often complain of arthralgias and myalgias, and they just feel terrible on taxanes. Okay, it's a tough drug. These are natural products. Okay, they were discovered from the yew tree, and actually the yew tree almost went extinct because we were harvesting so much of the bark for these drugs, and we were doing it in a very inefficient manner, and they were dying out. Fortunately, now it's semi-synthetic, so we no longer need the yew tree, and so they're doing well. So what happens here with our taxanes is it's encouraging the normal microtubule production and polymerization. Okay, however, it's getting embedded into it, and then eventually it just stabilizes the whole microtubule, and it prevents it from pulling the sister chromatids apart, and so you kind of get this failure to launch. So everything looks good until you're ready to pull them apart, and then it doesn't, and then the cell dies. Okay, so the same result for Vincas, but just a little different mechanism. So talking about pre-medications and hypersensitivity reactions, so initially up to 30% of patients who were getting paclitaxel experienced pretty severe infusion reactions. Okay, and the reason for that, as I mentioned earlier, is the castor oil that's used to solubilize paclitaxel. So we need to give every single patient who's getting paclitaxel, they have to be on an H1, an H2, and a corticosteroid. Okay, and even then, some of them will react. Docetaxel can cause capillary leak syndrome, can cause edema, and so dexamethasone can be given for a few days before and after to help reduce this inflammation. Okay. We do have other taxanes, so the most notable one here that you'll see is Abraxane. So instead of having castor oil, this is actually bound to albumin. So our rate of infusion reaction is next to nothing. Okay, so if a patient reacts violently to paclitaxel, this is an alternative agent that we can give them, and that's important. It's important to have alternatives that patients who react can move towards, and Abraxane is one such agent. All right, moving to our topoisomerase inhibitors, we've got Topo 1 and Topo 2, so only a few agents here. Irinotecan is the main Topo 1, and etoposide is the primary Topo 2. These just prevent the uncoiling or recoiling of the DNA strands as they're replicated by DNA polymerase. Okay, so they are cell cycle specific. Camptothecans were first approved in the U.S. in 1996. Okay, this is actually a drug that has pharmacogenomic implications. Okay, so if you've got 2 copies of UGT1A1 28 allele, you're at higher risk for complications. Okay, and so that's a topic for another day. But we primarily see irinotecan as part of FOLFIRI, okay, or FOLFIRINOX, which is used in colon cancer and pancreatic cancer. The primary toxicity here that everybody seems to remember, which is good, is diarrhea. Okay, you can have acute or delayed diarrhea, right? You run to the can, irinotecan. Etoposide we'll see all the time in small cell lung cancer as well as testicular cancer. Okay, tinipicide we don't really see as often. Now, etoposide also has polysorbate 80, so we do see some infusion hypersensitivity reactions with this drug, along with myelosuppression and mucositis. Now, the rate of hypersensitivity reaction with etoposide is nowhere near 30%, like we saw with paclitaxel. Okay, so this could be up to 5%. It's due to polysorbate 80. Tends to be just a type 1 hypersensitivity reaction, usually manifesting as hypotension. Okay, so if a patient's blood pressure drops while on etoposide, we'll slow down the infusion, and
and they typically do just fine. Now, if the hypotension is not relieved, if they continue to have problems, or if they have a severe reaction, we can always switch over to etoposide, which is etoposide bound to phosphate. Okay, so we're getting rid of the polysorbate 80 component. All right, bleomycin. So this was discovered in 1962. Very unique molecule derived from streptomyces. And one striking feature is the fact that it's one of the only chemo agents that we have that does not cause myelosuppression. Okay, so pretty unique. It's got two mechanisms here. It's got DNA binding, and then it forms some free radicals. Okay. So the main place we see this is in testicular cancer. So I always think of Lance Armstrong, who had testicular cancer, and he refused the curative regimen that involved bleomycin. So he got all the other agents, cisplatin and etoposide, but not the bleomycin, because he didn't want the pulmonary toxicity that can result. Okay, so bleomycin has two noteworthy toxicities. Okay, pulmonary fibrosis, as well as cutaneous reactions, and both of these are because bleomycin hydrolase is not found in the lungs and it's not found in the skin, and so this drug tends to accumulate, causing free radical damage and ultimately resulting in pulmonary fibrosis or dermatologic toxicity. Okay, so that's our cell cycle specific agents. Now let's transition to cell cycle non-specific agents. So unlike their cell cycle specific counterparts, these agents exert cytotoxicity regardless of the cell's location within the cell cycle. So they might not even be in the cell cycle at all, and it can still kill them. Okay, so they attach DNA onto DNA indiscriminately. So we'll talk about some very specific and targeted drugs in this boot camp, but these agents are the exact opposite. Okay, think of them as big, bulky bombs that we're just dropping into the body, and they blow up and they damage everything around them. Okay, these are dose-dependent cell kill agents. So the bigger the dose, the more likely we are to kill more cells. Okay, so doesn't matter if the cell's in the cell cycle or not. If these drugs come into contact with the cell, it will likely kill them. We have two major classes, alkylating agents and then our anthracyclines. Okay, so alkylating agents, these are the penicillins of the chemotherapy family. There's at least 7 classes out there. Okay, they're the oldest and the largest class, and they typically result from an electrophilic attack on the nucleophilic stable DNA, and this is typically on the N7 position of guanine within DNA. Okay, and so that's typically what they're doing, is they're binding to DNA and then preventing DNA replication because you've got this molecule attached to it, so DNA polymerase can't go through and copy the base pairs. So here's an example of cisplatin, which is just a small molecule binding to either the same strand of DNA or separate strands of DNA. So we have intrastrand or interstrand cross-linking, and that inhibits DNA synthesis. Okay. So the primary toxicity we see is myelosuppression, with 2 notable exceptions. So cisplatin is nausea, vomiting, and oxaliplatin tends to be neuropathies, but everything else for the most part is myelosuppression. Other complications we may see with this, other than the nausea, vomiting, and the myelosuppression, are alopecia, infertility, and then since we're damaging cells indiscriminately, this is leading to more mutations and potentially more malignancies down the road. So cisplatin, some significant toxicities to remember: nausea, vomiting. Okay, this used to be called cisflatin because of its horrible nausea, vomiting concerns. So patients would throw up possibly 12 times a day while on cisplatin. Okay, it was both acute nausea, vomiting as well as delayed, so that might go on for several days. Can cause nephrotoxicity, which we'll talk about in the next section, electrolyte disturbances, and ototoxicity. Now carboplatin I kind of think of as cisplatin's little brother, has all the same attributes and features, but kind of toned down just a little bit. So still causes nausea, vomiting, and nephrotoxicity and ototoxicity, but they tend to be less pronounced. I do need you guys to remember the Calvert formula. So this is how we dose carboplatin. So if you remember, we have a target AUC, so maybe 5, and then we add that to the creatinine clearance plus 25. Okay, and so you'll have lots of opportunities to do sample calculations. We might dispense 5 or 6 doses of carboplatin every day, and the pharmacists are always double and triple checking that the dose is correct. So again, just a summary table here of these platinum agents. We see them all the time: lung cancer, testicular cancer, ovarian cancer, colorectal cancer. So these are 3 of the more common agents that we see. And we'll talk more about their toxicities in the next section. Some other alkylating agents that we will come across, this tends to be cyclophosphamide, which is a nitrogen mustard. We see this in R-CHOP for non-Hodgkin's lymphoma. We see it as part of the AC regimen for breast cancer, and we'll also come across it in our chronic lymphocytic leukemia patients. IFOS is used less often, but we still see it from time to time. The major complications for both of these drugs, myelosuppression and hemorrhagic cystitis, which we'll talk about. There are lots of other alkylating agents, but we tend not to see them very often. So I want you to know that they exist. Again, it's the largest class, but we don't use them very often. They tend to be very toxic and non-specific, and we just fortunately have better options now. We do have anthracyclines, which is an important class. These are very, very, very commonly used drugs. These are doxorubicin and daunorubicin. They get their ruby name from the deep red color they possess. There are 3 mechanisms of action I want you to remember. So the first one is a quinone group that leads to free radical formation and DNA breaks. Okay, second one is this planar structure that leads to DNA intercalation, and then the third one is it does have some topoisomerase II inhibition. Those are the 3 primary ones to remember. Now doxorubicin is the main one we see, and we see it a lot in breast cancer. We see it in both non-Hodgkin's and Hodgkin's lymphomas, and then we see it in leukemias as well. Lots of toxicity from these agents that are noteworthy. We should be mindful of. So cardiotoxicity, extravasation, which we'll talk about on the next slide, mucositis, it does run through the liver, so hepatotoxicity, nausea, vomiting, red secretions, okay, lots of myelosuppression. So extravasation is a big deal, and something that the nurses will call the pharmacist and ask us what to do. So I had just the other day a drug extravasate, and the nurse called and asked what we do. We pull the guidelines and we look and see if it's a vesicant or an irritant, and then we provide them with best practices for that particular drug. Now doxorubicin is one that fortunately I haven't come across, primarily because we always give it through a central line. So those lines are not going to typically have problems. They're not going to blow a central line like you would a peripheral line. So all of these, you can see, for the most part, are peripheral lines that have gone bad. So we tend to force the providers to give it centrally. All right, so just a quick review here. We've got cell cycle specific agents. These are schedule dependent. They work in different phases of the cell cycle, and they primarily inhibit highly proliferative cells and cancers. Major toxicities really depends on the class, but anytime you have a rapidly growing cell type, you're going to see toxicity there, such as hair loss, nausea, vomiting, GI distress, myelosuppression, and so on. Now, cell cycle nonspecific, they act indiscriminately, dose dependent, major toxicities, myelosuppression, nausea, vomiting, infertility, alopecia, and secondary malignancies, and we see these with our alkylating agents and our anti-tumor antibiotics. Looking at some of the important side effects that we've talked about that are not myelosuppression, we've got cisplatin causing nausea, vomiting, oxaliplatin leading to peripheral neuropathies, vincristine causing peripheral neuropathies, 5-FU and capecitabine, got irinotecan and diarrhea, and then bleomycin causing pulmonary toxicities. So these are the non-myelosuppression dose-limiting toxicities, and we'll definitely cover these in the next video. So in summary, chemotherapy plays an important role in cancer treatment, and now we have hundreds of available agents to choose from. Okay, we have a plethora of agents. Lots of different classes and mechanisms of action exist, so we don't typically give the same agents or the same class to a patient at the same time. We'll usually pick and choose different agents depending on their mechanism of action so that we get synergy and we attack the cancer from all different points. Chemotherapy unfortunately leads to toxicity, which often involves rapidly dividing cells, and the pharmacist must know the side effect profile of these regimens in order to properly prevent and identify common complications. We're the ones that are in charge of this and responsible. All right, I hope that was informative, and we'll talk about the toxicities looking at Chemo Man in the next video.